Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 1 of 2 on the clinical assessment of visual function. First, we discuss the refractive state. In approaching a patient with reduced vision, the first step is to decide whether refractive error is responsible. In emmetropia, parallel rays from infinity are focused perfectly on the retina. In myopia, the globe is too long, and light rays come to a focal point in front of the retina. Near objects can be seen clearly, but distant objects require a diverging lens in front of the eye. In hyperopia, the globe is too short, and hence, a converging lens is used to supplement the refractive power of the eye. In astigmatism, the corneal surface is not perfectly spherical, necessitating a cylindrical corrective lens. With the onset of middle age, presbyopia develops as the lens within the eye becomes unable to increase its refractive power to accommodate on near objects. Testing vision through a pinhole aperture is a useful way to screen quickly for refractive error. If visual acuity is better through a pinhole than it is with the unaided eye, the patient needs the refraction to obtain best corrected visual acuity. The Snellen chart is used to test acuity at a distance of 6 meters or 20 feet. A scale version of the Snellen chart, called the Rosenbaum card, is held at 36 centimeters or 14 inches. All subjects should be able to read the 6/6m or 20/20 foot line with each eye. The pupils should be tested individually in dim light, with the patient fixating on a distant target. Pupillary constriction is the normal response to light. There is no need to check near response if the pupils respond briskly to light, because isolated loss of constriction or miosis to accommodation does not occur. However, it is important to test near response if the light response is poor or absent. Light near dissociation occurs with neurosyphilis, Argyll-Robertson pupil, with lesions of the dorsal midbrain as in Parinod syndrome, and after aberrant regeneration such as in oculomotor nerve palsy and adystonic pupil. A relative afferent pupillary defect or a Marcus-Gunn pupil is elicited with the swinging flashlight test. In dim light, both pupils are equally dilated. If the left eye is affected, shining a light on the right eye evokes equal and strong constriction of both pupils. Swinging the flashlight over to the damaged left eye causes dilatation of both pupils not equal to pupil size in a dark room, or it can also be interpreted as reduced constriction of both eyes. Swinging the flashlight back to the healthy right eye would result to symmetric constriction similar to the first illumination. These findings are usually seen in conditions such as retrobulbar optic neuritis and other optic nerve diseases. Subtle inequality in pupil size up to 0.5 millimeters is a fairly common finding in normal persons. Anisocoria that increases in dim light indicates a sympathetic paresis of the dilator muscle. The triad of miosis with ipsilateral ptosis and anhidrosis constitutes Horner's syndrome. Anisicoria that increases in bright light suggests a parasympathetic palsy. The first concern is an oculomotor nerve paresis. The possibility is excluded if the eye movements are full and the patient has no ptosis or diplopia. Damage to the ciliary ganglion in the orbit may result in acute pupillary dilatation or mydriasis. Common mechanisms are infection, such as herpes zoster and influenza, blunt, penetrating, or surgical trauma, and ischemia, such as in diabetes and temporal arteritis. After denervation of the iris sphincter, the pupil does not respond well to light, but the response to near is relatively intact. When the near stimulus is removed, the pupil redilates very slowly, compared with a normal pupil. Hence the term tonic pupil. This is seen in Addy syndrome, multiple system atrophy, segmental hypohidrosis, diabetes, and amyloidosis. Occasionally, a tonic pupil is discovered incidentally in an otherwise completely normal asymptomatic individual. The diagnosis is confirmed by placing a drop of dilute pilocarpine into each eye. Denervation hypersensitivity produces pupillary constriction in a tonic pupil, whereas the normal pupil shows no response. In Addy syndrome, a tonic pupil is present, sometimes in conjunction with weak or absent tendon reflexes in the lower extremities. This benign disorder, which occurs predominantly in healthy young women, is assumed to represent a mild dysautonomia. Dilatation of the pupils or mydriasis may be pharmacologic by deliberate or accidental instillation of anticholinergics such as atropine or scopolamine. Gardner's pupil refers to mydriasis induced by exposure to tropane alkaloids contained in plants such as deadly nightshade, Jimson weed, or angel's trumpet. Both pupils are affected equally by systemic medications. They are small with narcotic use such as morphine and oxycodone, and large with anticholinergics such as scopolamine. This ends part 1 of clinical assessment of visual function. Next set of slides will be part 2 of clinical assessment of visual function.